our next panel, I'm excited about the facts of menopause hormone therapy with Dr. Sharon Malone and Dr. Mary Claire Haver. And we'll bring them on up. Dr. Mary Claire Haver is an OB/GYN and certified culinary medicine specialist in 2021. Dr. Haver left traditional medicine and opened Mary Claire Wellness, which cares for the menopausal patient. And she just published her second book, The New Menopause, this week, as a matter of fact. Dr. Sharon Malone is the Chief Medical Advisor to Alloy Women's Health, a digital health platform for perimenopause and menopause treatments. Before that, Dr. Malone was an OB/GYN in Washington, D.C. for over 30 years. She is the author of the New York Times bestseller, Grown Woman Talk, which came out just a few weeks ago. All right, I'll let you take it away.
Okay, thank you all for coming out. I just love this, and nothing makes me happier than having a conversation with my friend, Dr. Mary Claire Haver. We are out here, and we've been doing this for quite a while, have we not? And we really want to have this conversation to make sure that women understand what's available. And our topic today is really the facts about menopausal hormone therapy. And I think the first place to start is really at the beginning. What is menopausal hormone therapy? It has a lot of names. It is now menopausal hormone therapy. It used to be known as hormone replacement therapy because I've been around long enough that that's what we called it back in the day. It's also called estrogen therapy. It's estrogen progestin therapy. These are all names for the same thing. And basically, it's using hormones to treat a hormonal problem. And now, as we have more options, testosterone may even be part of the menopausal hormone therapy. So, as we're talking about this, just know that we're talking about general class and that we're using hormones to treat the hormonal transition. It doesn't always start in menopause. We actually can start treating these symptoms because we know that they may occur 4 to 10 years before you actually get to the last period. And so depending where you are in the spectrum, as Dr. Larkin said, sometimes we use birth control pills, which are hormones, by the way, for people who are afraid of hormones, but they've been taking birth control pills for 25 years.
Or vice versa. Like,
Yeah.
birth control's getting a bad rap on social media.
Which that's a whole other conversation about why that is the case. But nonetheless, just know that when we're talking about class of medications, hormones used to treat hormonal issues.
So when we talk about menopause hormone therapy, we have systemic therapy, and I'm losing my voice. I've been on a book tour, so sorry. And then we have local therapy under the big umbrella. So for systemic therapy, it's something either goes through the skin or we take orally or goes through the mucosa, and it treats everything. It goes into the bloodstream and it hits every organ's system in our body: brain, bones, heart, lungs, kidneys, everywhere, general urinary system, etc. Local therapy is usually topical. Okay, we're using it locally, generally in the genital urinary area, sometimes on the skin. It's a little controversial, but so in the systemic category, we usually start with estrogen. When we're talking about menopause hormone replacement therapy, estrogen is kind of the mainstay of what we're talking about. And then if you have a uterus, progesterone is mandatory to protect the lining of the uterus from developing endometrial cancer from unopposed estrogen. Okay? If you don't have a uterus, or you have a progestin-containing IUD, or you were born with, you had a hysterectomy, whatever, progesterone is optional. And for some patients, adding in progesterone may be a little more helpful for sleep or some of the nighttime racing thoughts and anxiety, though it's not FDA approved for that. If you don't have a uterus or have that progesterone IUD, estrogen only is generally where we start with patients for menopause hormone therapy. So when we talk about estrogens, so we have estrogens, we have androgens, and we have progestogens when we talk about chemical formulations. Lots of terms out there that you'll see in layman's social media and news reports about bioidentical and synthetic and all these different things. Bioidentical, or in the UK, body identical, just means it's chemically similar to what our bodies made. So our ovaries make estradiol by and large. They make several smaller estrogens, but they're not really clinically that relevant as far as we know. Estradiol is the main one. That's the powerhouse. That's the one that is through our reproductive years. Estrone, you'll hear about. That is what is created in the periphery, usually in fat cells from peripheral conversion from androgenic precursors. That is the dominant estrogen in a postmenopausal woman because our ovaries have stopped making the estradiol. Estriol, which is in some formulations, is what our placentas make if you've ever been pregnant. Okay, but it is formulated and is occasionally used in different formulations. But by and large, those of us who do routine menopause care use estradiol for menopause hormone therapy. Sorry, I'm trying. I'm joking. So for the progestogens, we have progesterone, which is the body identical one. That's what our ovaries make. And then we have progestins. Again, a lot of controversy and a lot of misinformation about synthetic versus natural. Progesterone molecule is humongous, okay? And it doesn't pass through the skin very well. So if any of you have been given a progesterone cream with your estrogen in whatever form, talk to your clinician because probably you're not covered. More than likely, this is not enough. You're not getting enough penetration through the skin to protect the lining of that uterus. Okay, so I'm really hesitant. I've never prescribed progesterone creams for anyone. The progestin, like in the Combi patch, it works great. Okay. For my patients, I typically, when I'm going to give a progesterone, it's going to be the oral micronized progesterone. The testosterone, another tricky business because we don't have an FDA-approved option for women. So that's the main androgen. You don't want to do an oral form. It can be hepatotoxic. There's a lot of issues. Unless it's undecanoate, that one's actually safe. It's not available in the U.S., mostly, I think, in Australia. So, so if you're going to do a testosterone option, you want to do a non-oral option like the cream. So FDA has the male-approved versions of like T-Stem, the gel. If you're lucky enough in your state that you can get a pharmacist to prescribe it to you, that's typically what we try to do. I live in Texas, and there's no one that likes to get more involved in a woman's health care more than a Texas state senator is a Texas state pharmacist. So I've had patients who were slut-shamed, and accused of transitioning when they tried to pick up their T-stem gel. It's horrible. And so for a lot of us, we kind of are left with the, not our favorite option, but to compound something. Because when something's compounded versus FDA approved, I love compounding, I love having options, but we really try to stick to FDA approved options because they're tested, they're clinically tried. There's a 98% chance of what they say is in that box or that jar is in there. The compounders are just making it up batch by batch. No one's really running behind them to do a lot of testing, okay? So that's really the overview of systemic versus local.
And can I say this, because I think this is really important, because there's a lot of confusing terminology. Someone says, I want natural, I want synthetic, I want bioidentical. And this is, I think, a really important point for you to know. The only natural estrogen is Premarin, and natural means it exists in nature. Now, it happens to come from pregnant mare's urine, but that's natural. Everything else is synthetic. Synthetic simply means it is taken on a pejorative term, but synthetic just means that it is man-made. So even the estradiol, which is bioidentical, which is the same hormone that we make, if you drew it on a chalkboard, it would have the same chemical structure, it's made. Same thing is true with progesterones, the progestogens. You can have, when we talk about synthetics, we're usually talking about the non-bioidentical progestins that are used in birth control pills and some menopausal hormone therapies. However, even the bioidentical progesterone is synthetic. So I don't want you to get the terminology confused because it is sometimes very confusing, and that we like terms like, but I want natural, I want organic, I want, and this is something that I do say from time to time. I said, well, you know what really is organic? Bullshit. Very, very organic. So sometimes all I say is just be aware, and that when you're looking at terms, what does it really mean in terms of the effectiveness? So this conversation is really about estrogen, progestin. Let's not get caught up in the terms right now because they're both, all of them are bioactive, which is what we're trying to use to treat.
So when we talk about a birth control pill or birth control patch or ring, when we talk about contraception, hormonal contraception versus menopause hormone therapy, the biggest difference is dose. Contraception was developed, hormonal contraception was developed to stop ovulation, so no egg, no baby, okay? It happens to treat a whole lot of other stuff, menorrhagia, acne, dysmenorrhea. We use it for heavy bleeding, cramps, all those things, okay? When we stop ovulation, those things get better. Menopause hormone therapy was developed to stop hot flashes, and you need much less than what is required to stop ovulation. So I have to talk patients off the ledge when I suggest using a birth control pill for their perimenopause, especially if they're having dysmenorrhea or acne or whatever else on top of all of their perimenopausal symptoms. Like, oh, I don't want birth control. I'm like, it's just a little higher dose. I mean, the difference between a low dose birth control than low estrogen and the higher dose menopause hormone therapy is very small. And so, these are tools in our toolbox to help you. And, not to be suspicious because of something you read or, and remember, a lot of these terms are marketing terms, not medical terms. I would never pick up the phone and call Sharon Malone and say that, I'm going to give someone bioidentical whatever, or she has, what's my other favorite one? She has estrogen dominance.
Oh, yeah, estrogen dominance. Yeah, there's a lot. But and the one thing, before we leave the systemic conversation, I really want to say that systemic hormones can exist orally or transdermally, and that transdermal just means that's pills, that's patches, sprays that go through the skin. There's even a ring that you can use that's taken through the vagina. That is a hormone therapy replacement level, but we don't use that very much, but it is available. And then oral just means it just goes through, you take it as a pill, goes through the liver. And then all of the local hormones that we use are, by definition, transdermal because they're used typically vaginally.
Or transmucosal, yeah. Okay, I think next slide. So when we talk about the potential symptoms that these medications can be helpful for, and this goes along with the last talk, we know we have the things that the FDA has, we've done tests, it's proven, and that's going to be your vasomotor symptoms, so your hot flashes, your night sweats, and they're trying to include palpitations in that, which we now think is a vasomotor symptom, though not FDA approved for that. Prevention of prevention of osteoporosis? Mm-hmm. Yeah, and but also it's great for the 90% of us. The last study I read, 90% of us will have some form of dysfunctional uterine bleeding during our perimenopause. These medications can be great for that. Who had the crime scene periods during perimenopause, and we're rushed to surgical options instead of hormone therapy that probably, at least a trial to see if it could take care of the bleeding and all the symptoms that you were having.
Yes, and the number one reason why perimenopausal women come in to see their gynecologist is usually because of the bleeding. They don't even, because you're not even thinking about some of this being menopausal symptoms, but the amount of bleeding, and it really breaks my heart, what we normalize as women. We have gotten to the point where we have just normalized the language of suffering because we think that's as women, that's what we do. We suffer through cramps. We suffer with migraines. We suffer through the heartbreak of psoriasis. And we just feel like that's normal. But because we don't talk amongst ourselves, normal is what's normal for you. So if you've been having 7 to 10 day periods, you just figure, well, that's normal. It's not. And if you are having periods during this perimenopausal transition that make you never be able to be more than 5 minutes away from a bathroom, or you are wearing adult incontinence products to control your bleeding, that is not normal. And so this is the conversation that we really want women to understand, that from perimenopause into menopause, and we sort of know those, the symptoms, the hot flashes, and thank goodness Dr. Larkin said that. Hot flashes, let me just say this, are not benign. They're not funny. They're harbingers of sometimes of impending cardiac disease. When you have hot flashes, it disrupts your sleep. It worsens your brain fog. It makes you make bad dietary choices the next day. Lord knows that does. And you're certainly not feeling like exercising. So when we talk about all these potential symptoms, even though we talk about the hot flash a lot, just take note of what's here, and it helps you know when to access care. Don't normalize feeling bad, because Dr. Haver and I are really trying to change that narrative for women as we age. The expectation shouldn't be that getting old just means, oh, well, I'll feel bad. No. We're here to tell you that there are things that you can do and medications that you can access that will improve the quality of your life. And I think that's important, and that's something we've got to start choosing for ourselves.
Right. I love the last chapter of her book. Has anybody read Grown Woman Talk yet? Where you talk about becoming a benefactor and not a burden.
Yes. This
is a conversation I have with my patients. When we're mapping out her next 30 years. Typically, my patients are multiple ages, but, I'm 50, almost 56. And we're talking about what are your risk factors, like Dr. Larkin and Dr. Christmas talked about, like how are we setting your path so that, I call it my nursing home prevention program, what are the tools in our toolbox? Menopause hormone therapy can be a huge part of this. Now we're going to talk a little bit about prevention. It takes a while for societies to catch up and guidelines, but the data on cardiovascular disease is clear. The benefits, if you start hormone therapy within 50 to 59, within 10 years of your menopause, you have a lower risk of cardiovascular disease, as much as 50% per year. And so it's very protective for that disease. So those are the conversations that we're having with patients. The acute stuff, the hot flashes, things, the brain fog, yes. But then we're also trying to help her map out, could this be another tool that's going to help you be a benefactor and not a burden on your children?
And the one thing that we really, as we're talking about it, I'm sure all of you are sitting out there going, well, my God, if it's that great, why aren't we all taking it? And yeah, isn't that a question? But we have to own why that is. And, and without going into great depth, and we can, it started, for those of us, let me just say, I've been practicing, I'm 65 years old, and so I practiced for 10 years before the Women's Health Initiative came out. And the conversation about hormones and hormone therapy and who we were prescribing for was very different than in the post-Women's Health Initiative era. So that notion that you have in your mind about hormone therapy being bad, hormone therapy causing cancer, hormone therapy not helping you, really came from that one pivotal study. And I remember that fateful day when the regulators at NIH held that press conference and said all these terrible things. Well, women flush their hormones down the toilet. And again, it's disadvantaged a generation of women in the 22 years since then who have grown up with the idea that hormones is bad. And we've also disadvantaged an entire generation of physicians who also think that that's bad. And that's been the conversation that, that we're trying to have and trying to dig out of that hole. But the one thing I want to tell you about this is that, and I really have to give credit where credit is due, because I'm of the old group of people. And, when that study came out, the reality is that many of us understood the flaws in the study in 2002. The problem was I'm trying to convince you in my office, and there are many, many researchers out there and doctors who complained mightily from the very beginning. Dr. Phil Sorrell, Dr. Avram Blooming, Roger Lobo.
Simon.
All of the, who were saying, whoa, wait a minute. But we talked amongst ourselves, and that conversation sort of never made it out into the general sphere. And I say this a lot. I said, you get indicted on page, on the front page, and you are acquitted on B-17. Nobody saw that part. And so this conversation has been ongoing for years. So I don't want to give you the impression that we all of a sudden just learned something new about the interpretation of that data. It's always been problematic, and we have discussed it, and unfortunately, we were not able to communicate that to the public effectively. And that's why I said, let's give credit where credit is due to the people like Dr. Mary Claire Haver, who have been out there in social media. It has actually broadened that conversation, because I don't have to have it. I could have it one-on-one for, all day, every day, and still it would only be a drop in the bucket. But now I think that through understanding that there's a different way that we educate women, it's facilitated this conversation. This would have never happened 15 years ago without social media and getting women really activated about this issue.
And the Menopause Society, Lisa, Dr. Larkin, they are not part of American College of OB-GYN. They kind of this was kind of radical what they did, decided to make a clinical society, off the reservation. When we look at the American Board of OB-GYN, I get my board certification, many of us do every year. We go read a bunch of articles and whatever. There's no menopause category. There's gynecology and surgery and obstetrics and pediatrics and oncology and all the important things, very important stuff, right? There's no menopause section. It gets buried in office practice and geriatrics,
Right. Now, and we're going to get back to the issue at hand, but I think it's really important that you understand the context. How did we get here? Where did we start? What happened that changed everything overnight? And then how we are gradually trying to get back into getting women activated. And let me say this, because I think it's very important. We are not here to tell you what to do. I think that we are here to give you information such that you can advocate for yourself and access hormones and not allow doctors to tell you what you can and cannot have. Because understand this, a lot of times you're getting information from someone who does not know what they're talking about. And anytime someone says, well, my doctor said I can't have that, and I will say, you know what, perhaps you should have your doctor read the North American Menopause Society's 2022 guidelines, which have revised everything that we think about hormones. And a lot of the myths and things that we think the reasons why we take ourselves out of that conversation are not true. And this information is so vital because it is evidence-based. You don't have to say, this isn't Mary Claire Haver's opinion or my opinion. This is a consensus of experts who have said, all right, this is what the data is. Let's walk back some of the misconceptions that we've had about hormone therapy.
So, as most of you know, we're not educating our providers. That's a huge, in the new bill that's been put forth yesterday or day before with Halle Berry, it was in the news. I think 50 million of that is for education of clinicians, because we have a huge gap. And, so that we can all bring each other. Right now, we're Band-Aiding. You can run over here to telemedicine or go over here to concierge practice or pray to the hell that your OB-GYN cares or has had enough time to read something, But I really don't think that this should be dumped on the lap of the poor, busy OB-GYN who's trying to deliver babies and do your pap smears and everything. This should be mandatory curriculum for every physician who touches a woman. I'm in my clinic, I'm part cardiologist, part rheumatologist, because those specialties are struggling to get up to speed on how these menopause and how women are different than men in medicine. I mean, it's part of that bigger picture that was talked about earlier.
Right. And this is something that I want you to understand. And I don't know, I will not be conspiratorial as I become conspiratorial. But I will say this, it is amazing to me that when it comes to issues around women's health, and particularly anything about women's health that involves our reproductive systems, everybody's got a say in that. You know, as an OBGYN, I don't think I have ever once had a patient come to me who's getting their high blood pressure or their diabetes managed by their internal medicine doctor, and they come into my office and I'm like, oh, well, why are you taking that? Get off that. I don't believe in that. Who does that? Except when it comes to women and hormones care. No one owns it, but everybody wants to be in the conversation even when they don't know what they're talking about. So after all the time that we've spent sort of explaining to women, here are the risks, here are the benefits outweigh the risks if you fall within the parameters of who should take, and only to go to their doctors and their doctors will tell them, you gotta come off this. This is terrible, this is dangerous. I don't know what that's about, but I think that that is something that we have got to at least address within the medical profession ourselves, that we need to understand and respect our colleagues, because I don't think it's always a two-way street, particularly when it comes to OBGYNs and people who are trying to prescribe. I tell this story because it is true. I've been on hormone therapy for 15 years, full disclosure. I made that decision for me. I didn't need anybody to tell me that, but I made an informed decision, and I will stay on it for as long as I want to be on it. But I went in to see a new internist, and she said to me, as we're going over medication, she said, and I told her I'd take hormones, she said, I'm not a fan. and I was like, excuse me? You know what I do for a living, right? But the point being, if this is what she's telling me, then I know what she's saying to people who don't know better. And so for all the good work that we're doing about trying to educate, it gets undone on the back end. So let's get back to one of the things that when we talk about hormones, we have to say, okay, well, who should take, who can take, and who shouldn't take? Because I think that's an important thing for you to understand, because I think that the misconceptions about who can't take are not as great as you think they are.
So if you have active breast cancer or any tumor that's being fed by one of the hormones, you're not a candidate. You need to go through your treatment. You may never be a candidate, but you've got to get through your treatment for that. Breast and uterine are the two big ones. Not every gynecologic cancer is going to give you an increased risk of recurrence if you choose HRT after. There's a great article in the British Medical Journal about this. So a lot of misconceptions about that, but definitely, your breast and your uterine cancers. Unexplained vaginal bleeding, which 90% of us have, during perimenopause. So we're not going to rush to start hormone therapy. We need to get in to see the gynecologist, make sure that you've ruled out polyps or growths or possible endometrial cancer. So not a candidate until we get that figured out, all right? Severe liver disease, not mild fatty liver. I'm talking, active liver disease, liver cancer. We metabolize estrogens in our liver, and that process isn't going to work very well when our liver is diseased. So that's a really nuanced conversation, so not anything we'd rush into. And then history of blood clots and cardiovascular. If you have active cardiovascular disease, we don't want to put estrogen is better at prevention than cure in cardiovascular disease as far as atherosclerotic disease. It's very protective of the intima, the lining of those arteries going around the heart and in the carotids, okay? However, once those diseases start or you develop plaques, calcified plaques especially, then you probably, we need to get some workup. So when my patients come in and they have a history, high risk for cardiac disease, we're getting a calcium cardiac score at the CT scan around the heart. We're getting a full cardiac workup before we even start the conversation.
And here's something that I think that is very important too, is that we never say never. Because there are certain circumstances that is really outlined nicely in the North American Menopause 2022 guidelines, even about certain cases with breast cancer. It depends. It depends on the stage of your breast cancer. It depends on whether or not you have completed your therapy, your treatment for your breast cancer. And it depends on what your ultimate goals are and what your expectations are. So it's not even a never, never on breast cancer, because there are people that have triple negative breast cancer. There are people that have breast cancers, they've completed treatment as young survivors of breast cancer, and they are now 10 years past with no evidence of recurrence. There may be circumstances of which that is appropriate. But again, that's a conversation that you have with your doctor on risk, benefits, and your treatment goals, not a no, never, dear. You do get to be involved in an informed way and to make the decision about whether or not you want to treat your symptoms, because for young women, that's a real problem. And that is, and there a lot of treatment is being withheld. Even local, just vaginal therapy is withheld from a lot of breast cancer survivors. And at a minimum, everybody can have vaginal estrogen. It's not enough to affect your outcome one way or the other.
And there's not a one-size-fits-all. It's a lot of trial and error sometimes, especially in perimenopause. What works at the beginning of your perimenopause may not work at the end for your symptom control. So, it's so wonderful that we have options, not just the straight-up estradiol, progesterone combos, that we have some of the SERMs, basodoxifene, that we have some Veoza and some of the other medications for patients who are not good candidates. So don't feel like, oh my God, I'm not a candidate and there's nothing that we can do for my menopause. Look, menopause care is more than hormone therapy. It is nutrition, exercise, stress reduction, sleep optimization, all of that. It's synergistic together.
Here's another big one I think that women take themselves out of the conversation, and they will say, well, I can't take hormones because I have a history of breast cancer in my family. Who doesn't? When you think about the fact that most women will have, we say, a population statistic of 1 in 8 women will have breast cancer at some point in their lives, but your biggest risk factor for having breast cancer is living long enough to get it. Age is the biggest risk factor, not whether you take hormones or not. As a matter of fact, the overwhelming majority of women who get breast cancer in this country do not take hormone therapy. And I think we should take a little bit of moment and do a happy dance. Even though the incidence of breast cancer is increasing, the mortality rate for breast cancer has dramatically decreased since the 1980s, since we were, and then we were saying, my God, the mortality, it was terrible. And I think that's what cemented breast cancer is bad and uncurable and you will die. It is those old statistics, not the current one with with early diagnosis and treatment. Now, we're about to run out of time. So I think we want to run through really quickly some of the myths that you talked, and I think we've talked about breast cancer. Again, it does not
Right. So a healthy breast
breast
cell, right? We all are born with healthy breast cells, and then some of us undergo malignant transformation due to a zillion different reasons, lifestyle, genetics, oncogenes, whatever. And so estrogen, if you retain an estrogen receptor through the malignant transformation, they can use that estrogen receptor to kill the breast cancer cell. And so that kind of in people's minds is like, oh, estrogen is bad, and that,
Right.
and so we have our highest levels of estrogen typically in pregnancy, and breast cancer is very, very rare, except for the poor patients who usually have a very, genetic, reason for them to get breast cancer so young.
And here's the thing that I think is really an important thing for you to know about the Women's Health Initiative. That same study that told you that estrogen was terrible and it was going to increase your risk of breast cancer, let's put that in perspective, because 26% increase, and let's just take it at face value, and even there's some discussion about that, but let's take the Women's Health data as it was reported, a 26% increase in the risk of breast cancer. That sounds terrible, right? Oh, who wants that? But what did that actually mean in absolute numbers? That was only with women who took estrogen and progestin. And what they found for women who took estrogen and progestin, who took for more than 5 years, and that's when they stopped the study, they found that the annual incidence of breast cancer was 30 women per 10,000 women per year will be diagnosed with breast cancer. Why? Because you're a woman and you've got breasts. What did adding estrogen and progestin do to that risk? It went from 30 per 10,000 women per year to 38 per 10,000 women per year. less than 8 per 10,000, or less than 1 in 1,000 additional cases of breast cancer in women who took estrogen and progestin. Well, less than 1 in 1,000 additional cases does not sound nearly as scary as a 26% increase. But here's the other bottom line, is that even if you take that number, the less than 1 in 1,000, there was no difference in the survival rate of women who took estrogen versus women who didn't take estrogen. So you were no more likely to die of your breast cancer on or off hormone therapy. That's number one. And the second part that I think was really, that just went over everyone's head, is that there was an arm of the study that just did estrogen only. That we stopped at 5 years on the estrogen and progestin. The arm that for women who had hysterectomies and took estrogen only went on for 2 years, and they did not see an increase in the risk of breast cancer. And now we have the luxury of having a 20-year look back on those women who took estrogen and progestin and the women who took estrogen. And guess what? They have found that in the 20-year look back, the women who took estrogen only had a 22% decrease in the incidence of breast cancer and a 40% decrease in the risk of dying from breast cancer. Now, did you hear that? So you can't, we have to at least acknowledge that there's some nuance when it comes to estrogen and estrogen progestin. Is it the estrogen and progestin that's the problem? Is it not a problem? Clearly, the estrogen-only part of it does not implicate estrogen as the etiologic factor for why women get breast cancer. And I think that, again, these are the kind of conversations that we need to have as physicians. There's more research that needs to be done into this.
This is such an important topic, and it deserves its own,
Yeah.
So this fall, Dr. Lisa Larkin will be giving an entire presentation on breast cancer and hormone therapy.
Okay. All right, what are our other myths? Okay. Oh, this is yours.
See, number 2,
How long?
if you're relative, we kind of covered that. It's too late for me to start menopause hormone therapy. That's a maybe. I mean, estrogen therapy will always protect your bones forever. You started at 90. It was, protect your bones. You will lose the cardiovascular preventative benefits probably somewhere in that first 10 years. Doesn't mean you can't start it after 10 years. Again, I do a lot of testing, nuanced conversation, but if she's still symptomatic after 10 years or over 60 and she wants the other potential benefits, we talk about it. We try to do it safely and rule out other diseases that may, that we don't want to put estrogen with. There's no age at which we have to stop hormone therapy. If you're enjoying those benefits, those can continue as long as for you the benefits outweigh the risk. Nuanced conversation with your healthcare provider.
And that is something that has changed, because somewhere we sort of saying, when we were having the conversations between estrogen and hormone therapy is bad or it's not so bad, we kind of split the baby and said, well, it's kind of bad, but only if you take it, only if you take it more than a certain amount of time. And there was really no real evidence that said that looked at how long you should take hormone therapy. And yes, and that is one of the new things, that there's no reason why if you go to the doctor, you're good, you're healthy, you're happy at 60, and they go, oh, time's up. Time to start feeling bad again and having those hot flashes. No reason for that.
A woman should never use hormone therapy exclusively for prevention. Well, that's what the U.S. Preventive Health Task Force says, but I have a lot to say about that. So there's what we call the healthy cell hypothesis, or the timing hypothesis. Here's what we know. Women who go through menopause early have much higher risk of diseases for age-matched women who go through menopause later. It is the time away from estrogen that accelerates certain disease states. Insulin resistance, cholesterol levels, the risk for cardiovascular disease, abdominal fat deposition in the form of visceral fat. Those are non-negotiable. Okay, that happens through the menopause transition untreated. So estrogen is better at keeping you on the normal aging path, like we age, on that path that you were on pre-menopause. We're still aging. These things are still happening, and they're very interconnected, but we accelerate in several chronic disease states through the menopause transition. And what estrogen can do is slow that down as a menopausal person. And so these are the conversations that I'm having with my patients about potential, even though certain guidelines need to get their shit together and catch up.
And the one myth, I'm not feeling bad enough. I should wait until my symptoms are really bad before
It's not an
I
epidural.
start. Yeah, exactly. And look, exactly. And let me say that how bad is too bad? You know, I mean, I'm not into suffering. And I had done this long enough, and I believe women when they came in and they told me their symptoms. And when I got to the point where I was at, I'm like, no, I'm not going to sweat in the operating room. I am not going to be in the middle of my sentences. I'm giving a patient pre-op instructions and forget what I was talking about. Those are things that are important to me for my quality of life and my functioning. So no, but the time to start is when you say you're ready to start hormone therapy. We're not waiting for, oh, you only have 5 hot flashes, or you only woke up 2 times last night. You say, and only you know how you feel and when you are ready to access care. And that is, I think, a really important point for women to sort of, get activated and advocate for yourself on that front. Let's see, what we have, compounding. I think we sort of talked about bioidentical and all that. It's not, bioidentical and the ones that are compounded hormones, they are not safer. The only difference is that compounded hormones, because they are not FDA regulated, they do not come with the same warnings because they don't have to put it on the label. But that should not give you the impression that they are safer. It's what it is.
Do we have? All right, we have a couple minutes for questions. Somebody.
But we have, and we know everyone has so many questions, and we want to hear from you guys. So what we did is we have an upcoming menopause talk with our Chief Medical Advisor, Dr. Robin Noble, who could not be here today. She is fabulous, just like these other women who are up here. And we're going to take your question, come to that menopause talk to ask your questions. We will take one question, and then I think we do have to go to break.
I feel like I won the lucky prize. I'm going to play the lotto today. First of all, thank you both so much for your books. I cannot read fast enough, so I haven't finished them both yet, but they're literally in my hotel room. Question of something that I heard a lot and a lot of women hear. We also get diagnosed with IBS a lot. So many women get diagnosed with bowel symptoms and things like that. And so you couldn't pry my hormones out of my cold, dead hands, but doctors are quick to take you off of hormones because they will say a lot of times that they cause problems in the gut. Is there anything you know about
Zoe
this?
is here. So the largest nutrition study in the world did stool samples of where is she? Where is she's back there? Yeah.
I will find you.
So, and they tracked the gut microbiome through the menopause transition, and what they saw was a complete dysbiosis and going to the gut of a man. Now, nutrition is huge here. And we know there's something called the estrobolome, like the liver's metabolizing, we get these metabolites, and there's this recycling thing that happens. So gut health is healthier on women who are on HRT, and they showed it. So you have the profile is healthier of the gut microbiome. There's so much exploding research here. And whoever's saying that is their opinion. There's no data to support that, and that is not fact.
Thank you. Yay, I can stand my hormones.
That was so great. I have both of their books, and I've gifted them to my friends who are like the Menopause. So it's never too early to start preparing, and it's never too late, so thank you. And there are a lot of questions. I know that you all have them. There's going to be another talk in June, so make sure you sign up for that. And just remember, some of the things they were talking about were those negative things that you hear. So we've all been there. You can hear 99 great things, but one person says one wrong thing and you give that thought priority. So when you're having fear and anxiety about some of the scary anecdotes that you see online, just remember that, right? So please take a break. We're also going to talk about bone health at that talk later on, so save your questions for that.